So we are recording and we will be sending you the replays after the webinar and also anyone who's registered. So you can also drop your question in the chat as we go, and we'll get to as many as we can at the end. One important note is everything today is educational. It's not a medical advice. For anything personal, please talk to your own doctor. So now let me introduce you to our guest, because we are genuinely lucky to have her today. Dr. Chrisomalis, welcome. And thank you very much for being here today.
Thank you. It's my pleasure, actually.
Dr. Chrisomalis, you are one of the most respected OBGYN in New York, with over 30 years in women health. You trained at Columbia, where you completed a fellowship in maternal fetal medicine and spent 11 years as an assistant clinical professor caring for high-risk pregnancies and training the next generation of doctors. You opened your own practice on the course in 2005. You have been on Good Morning America, quoted in Cosmopolitan, Glamour, Shape, and Parents magazine, and you were honored by Barnard College for your mentorship of young women going into medicine. You speak 4 languages, French and Greek, and your patient always says the same thing. You give them real time, real attention, and genuine care. Lorraine, beyond being my friend for so many years now, you are by far the coolest, most vibrant, funniest OBGYN I ever met. You wear your Instagram title of Gyno Goddess better than anyone could. I am so happy you are here. I will let you take it from here.
Maylise, thank you for that beautiful introduction. Today, as Maylise said, I'm here to talk about perimenopause and menopause. I feel that there's a lot of information online these days about menopause and about perimenopause, and I think women need some good, clear information about what is going on during these periods in their lifetime so they can be educated about what to expect and then what some treatment options are. So the first thing I want to do is just tell you, what is the definition of perimenopause? So perimenopause, from the Greek menopause, peri, around the time of menopause. Menopause is a time when your period stops for 12 months. So perimenopause is the time before your period stops for the full year. So when your period starts getting irregular, that's when you're in perimenopause. So there are 2 stages of perimenopause. There's the early stage, where your period starts varying by about 7 days greater than the normal. So if you were someone that had your period every 28 days, for example, now all of a sudden you're starting to get your period every 35 days, every 40 days. So it's coming a little bit more irregular now, and that never happened before. If your period starts getting later than every 60 days, then you're in the late stage of the perimenopause. So there's an early stage where your period starts getting irregular by 7 days or more. And then when it gets a little closer to the menopause, it's more like 2 or 3 months that it can happen. So what are some signs and symptoms of perimenopause? So before I start going into those, I want to just say that the perimenopausal period is a very unique time in a woman's life. So one woman might present with horrific hot flashes. The other one will present with sleepless nights. So it's not each patient presents in a unique fashion, and some are more plagued by some signs than others. And therefore, the treatment regimen needs to be individualized for each patient. So what are some signs of perimenopause once we know that? The first one that I mentioned was the irregular menses. The second one is hot flashes. So this one is extremely common. So 75 to 80% of women will present with hot flashes. So all of a sudden they'll just get these like waves of heat that disrupt their daily life. For example, I felt like I had like a little like internal flame. So sometimes people would say, like, why aren't you wearing a sweater? It's so cold out here. I'm like, I have my internal flame. So that would keep me warm. So my hot flashes appeared like that. A lot of times these hot flashes can appear in the middle of the night. So sometimes a woman will get a hot flash, wake up, have insomnia and sleepless nights. So that's very common. The hot flashes and sleepless nights usually go together. A lot of times the woman will be with her husband and will like turn the air conditioning on, or will just change her pajamas because she's just drenched in sweat. And the husband will look at her like, what are you talking about? The temperature's fine in here. But she's not crazy, because there are things in the thermoregulatory center in the hypothalamus that are affected. There are these neurons in the hypothalamus, in the brain, that are affected and cause true hot flashes. The women are not going crazy. These are true things that are physiologic, that occur in the hypothalamus. So with the sleep disturbances, a woman has insomnia. She's not getting her good REM sleep, right? So she's not getting quality sleep. So what does that lead to? So sometimes it leads to mood swings. So she'll just be irritable and cranky and anxious, or just fatigued, just unexplained fatigue. She's not really sure why. Or with anxiety, for example, she'll get heart palpitations, and she never had heart palpitations in her life, but all of a sudden now just gets erratic heart racing for just no reason, right? And then with all that, if you're not getting good REM sleep, you're not getting quality sleep, what happens? Then you get the brain fog. Then you get difficulty concentrating, right? Your memory lapses. The patient whose name you remembered vividly because you've known her for 20 years, all of a sudden you're looking at her and you're going, oh. And you try to remember things about her to like get the name out. And sometimes you're just not as sharp. It's taking you a millisecond to remember someone's name, or to remember a word that you should really know. So you're not going crazy, right? Because there's definitely something physiologic that's going on. You're having decreased estrogen. There's receptors all over our body that I'm going to go into right now. One of the last perimenopausal symptoms, that's a very important one actually, is vaginal dryness. So vaginal dryness is when you get discomfort because there's less plump cells in the vagina. There's less estrogen affected cells that are plump that would give you a regular transudate. So now the vagina is dry. And with that comes difficult intercourse and dyspareunia. So why do you get all these symptoms, right? You get all these symptoms because there's estrogen receptors all over your body. And that's why we're getting these different signs and symptoms. So you have estrogen receptors in your brain, right? The brain is what regulates cognition and memory and mood. So that's why, hence brain fog, when you don't have enough estrogen. What about your breasts? Breast receptors are present in the, estrogen receptors are present in the breast tissue. And what about the vagina? We talked about that. The vagina, the mucosa can be a little dry, not as lubricated, painful intercourse. And what about your skin? Remember when you were pregnant, or if some of you were pregnant, or when you are pregnant, you get a glow, right? Why do you get a glow? You get a glow of pregnancy because there's estrogen receptors that make you have a glow. You have estrogen receptors in your hair. So your hair is luscious during the time of pregnancy. And then what happens after you deliver your baby, right? 6 weeks after you deliver your baby, all your hair starts falling out. So you have, hair loss because of estrogen loss. Now let's talk about the uterus. And this is really, really important to talk about. It's important to say that the uterine lining, or the endometrial lining, can get stimulated by unopposed estrogen, right? So if you have estrogen on board, it's going to stimulate the endometrial lining, cause endometrial hyperplasia, right? So with estrogen, it's going to cause endometrial, so the glands are going to get more stimulated. And sometimes if they get stimulated too much, you can get endometrial cancer, in fact. So what do you have to do? Every time you give a patient estrogen, if she has a uterus, you need to protect the uterine lining. You need to give them progesterone along with the estrogen. The only patients that are exception to this rule are the patients that have had a hysterectomy. So if someone's had a hysterectomy, there's no uterus that you need to protect. You can give them unopposed estrogen, but that's only with the guidance of a physician or a healthcare professional that's delivering the estrogen to the patient. Okay, so now I'm telling you about this, couple of years, 4 or 5 years, between 46 and 51, you're starting to feel these symptoms, and you're like, you know what, doc, can you tell me what's going to happen? When is my period going to stop? Can you tell me already? I'm exhausted. This is really, I hate having my period. Where am I in this schematic? Where am I in the scheme of things? So it's really easy to figure this out. You're going to get a blood test. You get a blood test on day 3 of your period, right? So if you get a blood test on day 3, it's going to check for FSH. So you go for the day 3 FSH. And what is FSH? FSH is follicle stimulating hormone. It's a hormone that's produced in the anterior part of your brain. And what does it do? It tells your ovaries it's time to produce a follicle. Usually on day 14, if you have a 28-day cycle, the FSH rises rapidly and it gives you a follicle. And then you have estrogen production. Okay. So if you want to obtain the FSH level at the baseline, the lowest possible FSH level, that's why we draw it on day 3. If you draw it on day 2, 3, 4, the FSH is still low. It gets really high at the time of the time when you ovulate. So we do not want to draw the FSH level on day 14 if you're having these normal cycles, because it's going to be falsely elevated. You want your FSH level to be as low as possible to indicate where you are in this schematic, right? So if your FSH level is between 10 and 24, 25, you're in the perimenopausal period. If it's greater than 25, then it indicates that you're in the menopausal state, and you confirm this with other signs and symptoms. Then in menopause, like we mentioned, you're not going to have your period for 12 months. So with this FSH level, you can find out where you are in the scheme of things. Is it early menopause? Is your number 8, 10, 11? Where it's just starting to get irregular? Is it the early part of perimenopause, or is it the later part? Or are you near 24, 25? And I can say to you, well, your period's probably going to stop soon. So, okay, so now what are some treatment options? It's really best to try to get someone during the perimenopausal state and treat them, because you have a gradual transition into the menopausal time. So it's some treatment options are birth control pills. You start with the lowest possible dose. You can start with a 10 microgram pill. You can go up to a 20 microgram pill if the patient's not feeling better. But I usually try to start with the lowest possible estrogen dose, because that's the safest thing to do. If a woman's going to be on estrogen for many years of her lifetime, we want to start with the lowest dose, because if the lowest dose works, why are we going to give her more estrogen than she really needs? So one option for treatment is a low birth control pill. A second option is a transdermal patch. This is a patch that delivers estrogen continuously and it gets absorbed. A lot of these patches are placed on the lower abdomen or on the buttock. Sometimes there's some issues when people shower. Sometimes they loosen up and the adhesive gets a little sticky and, black, or, it gets a little hard to remove from the skin. Sometimes just a little alcohol wipe just removes a little sticky part of the patch. Some people don't like that. Others prefer a pump. So you can just use a pump that delivers either 0.5 or 1 milligram of estrogen right to the forearm. You can just put it right on the forearm. If you're a traveler, sometimes the pump might not be so practical. You probably can't put that in your little packets, in the little travel packets. So sometimes I like, if patients are traveling a lot, sometimes they prefer these estradiol packets. They look like the packets that you use, like the bacitracin on. So you just rip them and you apply the estrogen right to your forearm and just rub it in. Now, what if you're a patient that's like, you know what, doc? Those pills, they never worked for me. They made me crazy. Or, you hate hormones. Like, I don't want to be on hormones. That's fine. There are some natural products that are available. Some of them are plant-based. So they're hormone-free plant-based. Some of them that help with hot flashes just work at the level of the hypothalamus. There's a neuron called the KND neuron, KND little y, and that's the one that produces the hot flashes. So they're hot flash blockers. So these KND blockers that block the woman from getting these hot flashes. So we can use those products. Sometimes there are products from like a Swedish pollen flower, for example. Those types of compounds can be used to help with menopausal symptoms. These are oral tablets, and then sometimes they work 60 to 70% of the time. They don't work instantly. You have to take them 2 or 3 months before you see any benefits of these medications. Now, in terms of managing the menopause care, I feel that the care needs to be by someone who's trained as an OBGYN or someone who's done internal medicine with a woman's health background, either an MD, a DO, a healthcare professional that has expertise in menopause, or someone who even obtains a menopause certificate from the North American Menopause Society. In fact, there are such certificates. I think your care should be by someone who knows exactly what they're doing. It is essential to get your personal history. So your history, your GYN history, your medical history. It's important to know if you have any signs or potential diseases that prevent you from getting estrogen as a product. You might be hypertensive, for example. You might have high lipids or high cholesterol. You might not be a candidate for hormonal replacement therapy. So we need to absolutely make sure that someone who knows what they're doing, a physician, gets your full medical history, make sure that you're not at risk for getting cancer. For example, if someone in your family had Lynch syndrome, you're at risk for getting endometrial cancer. You might not be that patient that might be a candidate for estrogen replacement therapy. So an excellent history taking needs to be obtained, as well as a full physical exam. So you might not realize you had a breast lump, for example. So if your doctor picks up a breast lump, there's no way that you are until further assessment of the breast lump, you are not a candidate for estrogen replacement therapy. Now, because of all this hype that's been online, it's really important to know that there's a lot of online clinics that offer you these medications, right? So there's telehealth visits that you can have because of the hype about menopause and perimenopause. So a lot of professionals or paraprofessionals are rendering healthcare, but just be aware of who you're getting your healthcare from. That's my only point that I want to make. If you're getting a telehealth visit, someone is not examining your body, or someone might not be obtaining a full history on you. So sometimes I'll get patients that have had telehealth visits that are already obtaining estrogen and progesterone and testosterone before they see me and then have complications. So I had a patient that was trying to tell me about her bioidentical hormones, how amazing it was when she was in California and she was obtaining these biomedical hormones from another country. And she was trying to educate me about the bioidentical hormones. But you know what? She was feeling great because she was probably on a really high dose of estrogen. So she presented in 2 or 3 years after seeing me with an endometrial polyp. So she ended up having a complication of the weight of the high estrogen that she was getting. So be aware of bioidentical hormones. Sometimes these compounds are made in foreign countries. I prefer an FDA-approved, US manufactured medication that I know is delivering 0.5 milligrams of estrogen when I give a pump. I feel safe that these products are delivering the amount of estrogen, progesterone, or testosterone that I would like to give. Please note that testosterone is a hormone that can be prescribed as well by your OBGYN, but it is a controlled substance. So if the doctor doesn't have a controlled substance license, they cannot prescribe the progesterone. So I hope I've made the perimenopausal period and menopause a little clearer. I hope I talked about the signs and symptoms so you can be aware about your body and what is going on during this interesting time. Know that every patient is unique, right? Every patient is having different signs and symptoms. So it's very important to get excellent healthcare and treatment options. It's important to render healthcare early on if possible and have someone glide into the menopause. Remember, we talked about how every patient experiences different menopausal and perimenopausal periods. Some women just slide into the menopause and glide in, while others, it's like turning a light switch on. All of a sudden they're feeling great, and the next day they're just plagued with all the signs and symptoms at once. Anyway, I hope I helped you understand perimenopause and menopause a little more. I hope you're in tune with your signs and symptoms, and that you do get healthcare providers that know about this disease. And if you have any further questions, you can contact me at my office at 55 East 86th Street, Suite 1B. I'm on the Upper East Side. My phone number is 212-879-7180. I have an Instagram account with where I am Gyno Goddess. So I'm signing off as Gyno Goddess, and I hope to see you soon. Now I guess we have a Q&A. So Melis, if you want to start a Q&A, if any of the audience has some questions for me, I would love to answer them.
Thank you so much, Lorraine. Yes, we're going to start with Fatima. She's asking, are some of the symptoms of perimenopause similar to fibromyalgia, how can we distinguish the difference?
So yes, indeed, sometimes when a patient is perimenopausal, she is fatigued. So fatigue is something that we need to figure out. Is it from the perimenopause because the estrogen levels are low? Or is it something autoimmune like fibromyalgia? So the patient would need to see her primary care doctor and perhaps even be referred to a rheumatologist that can figure out if it is fibromyalgia, because the treatment options for both groups are very different. One is estrogen, and the fibromyalgia would need a different treatment option. So that was an excellent question. Thank you, whoever asked that.
Great. Thank you so much. And Kathleen is asking, perimenopause and menopause are often associated with weight gain, particularly around the abdomen. Why does this happen, Lauren?
Thank you for asking that question. That was something I didn't include on my slides, actually. So I really think that's a very important one, especially these days. So how I describe it is estrogen is able to give you your curves. So before you get your period, you're about 10 years old. At least I was really round, right? So I had a big belly and little breasts, and my belly was fatter than anything. And then by 12 and a half, I got my period and I started getting a little bit of a waist. I never really got a big waist. I just got a little waist. And then some hips. So the estrogen helped in shifting some of my weight. So my weight wasn't around my abdomen, but I started getting weight shift near my hips, less near my waist. So what happens in perimenopause is that you don't have estrogen anymore. So you revert to this prepubertal state. You revert to a state before you had estrogen, kind of like when you were 12 or 13, right? When you didn't have enough estrogen. So your belly fat is usually surrounded, it's usually like right in your belly, where a lot of women are like, I never had this. I had a flat abdomen. And all of a sudden now I look like I have this little pouch. I never had this before. So it's because of the shift, because of the estrogen, there's a shift in weight. Now, just a little bit about the semaglutides. I think an endocrinologist would probably be better at answering this question. I don't know if anybody's in the audience who's an endocrinologist, but they might be a little bit better at answering this. I don't prescribe the semaglutides, but I know they have been life-altering for patients during the perimenopause, because it's the only thing that's been able to help patients that have been in this time period.
Thank you, Lauren. So yeah, we have a lot of questions regarding estrogen, and it's definitely a topic here. So if I start taking estrogen, is this something I will need to take for the rest of my life? Is estrogen always effective? If there is a possibility that it will not work, if there is a higher risk for taking estrogen, if I am already on other medication, can estrogen make me feel worse? What are the chances of getting pregnant during perimenopause? So that's just the last question, but yeah.
Oh my God, that's like 7 questions in one. So give me the first question first and I'll answer all of them.
If you start taking estrogen, is this something you will need to take for the rest of your life? And
that's a really good question, right? So that's very individual. Like some patients just take some hormonal replacement therapy and they kind of glide into the menopause. So they take some birth control pills for 4 to 5 years and they feel fine, and a lot of the signs and symptoms disappear. Others can have signs and symptoms for up to 10 years. I remember reading the article about menopause in the New York Times way back, and it said you could be menopausal for up to 10 years old. Like, dear Lord. But you know what? I'm 64 now, and every once in a while I do get my hot flashes. Every once in a while I do get a sweaty face, and I do get these signs and symptoms. So that's not far out. So I would say that some patients prefer to be on them for a long time because they feel great. They feel young. They feel youthful. It's great for their skin. It's great, if they're sexually active, it's good for their vaginal mucosa. So, it can be good. Some patients don't want to be on it for long. So I try to individualize the care. It's not unsafe if they've been on it for a while. Now, that being said, if someone comes to you my age, for example, at 64 and says, you know what, I've never ever been on birth control, but I want to get on now. There's so much hype about it. You know what? I just want to feel better. That might not be the first patient you want to be starting on birth control pills or starting them on estrogen replacement therapy, because it's a little more dangerous to start a person who's older on estrogen hormone replacement therapy.
great, thank you. And does it always work?
Does it always work? I mean, in medicine, we never say always. It's like we never say never, we never say always. It works for most people because, like I mentioned, there's a drop of estrogen. We can measure the estrogen the way we measure the FSH. You can measure someone's estrogen when you measure the FSH, and you can see, hey, how low are you? Are you, 100? Are you 450? So you can see where they are in the scheme
Yeah.
of things. Right?
And there is any medication that you cannot combine the intake of estrogen with?
Yes, there's a lot of medications that are contraindicated, and a lot of times, yeah, you'll get that information. A lot of
Oh,
times they'll
interesting.
say that.
Great. And what is the chance of getting pregnant during perimenopause?
Oh, there's a lot of oops babies out there. So definitely, you definitely can get pregnant during the perimenopausal period. I have a lady who's, just 45 years old with an FSH of 8.8. So that's a decent young person's FSH level. So if she's active, I'm trying to help get her pregnant. If she's active, she can indeed conceive. So remember we said the FSH levels vary erratically during the perimenopausal period. So if the FSH level's low, she can pop out a follicle and get pregnant. So there's a lot of oops babies in women's late 40s, maybe up to 45, 46, let's say. Not,
Thank
not,
you.
not more than
And
that.
so what is the side effect of estrogen? Can that make you feel worse?
So side effects of estrogen is you can have breast tenderness, you can have, lots of signs and symptoms of, uh, of estrogen. Some of them are pleasant though, like smooth skin and like good things like vaginal moisture, that kind of stuff.
Great. Thank you so much. So we have a question from Kathleen. What are some habits that should be avoiding during perimenopause, and what are some steps to take to improve my quality of life?
I think some steps to avoid are definitely smoking. So if you're a smoker, stop smoking. If you're drinking alcohol, we have to stop the alcohol. Always try to stay on a very healthy diet. That's what I would recommend. I don't know if there's a nutritionist in the audience, if they can chime in a little bit, but like a Mediterranean diet, a DASH diet, right? Something that's heavy on legumes and on vegetables, less red meat, fish, get healthy fats like avocado and get, your healthy fats from nuts, for example. When I went to Kos on my vacation last year and the year before, I came back 2 pounds lighter after 2 weeks, and I did nothing different. I walked a lot more. There's torrential, we were walking a lot more, we were swimming a lot more, but I wasn't eating the amount of red meat that I would have eaten. We had a little slab of meat that was delicious, but it was split amongst 12 of us. So we ate mostly different vegetables. So that helped in, providing good plant-based foods for us that kept us healthy.
Thank you, doctor. And we have a question from Angela. What are your thoughts on peptide for menopause?
I don't know enough about peptides to comment. That's an excellent question. I know there's been a lot of hype about them online. I think I'm not the expert about that, unfortunately. We can look into who is the expert and get Angela that question. That's an excellent question. I don't know enough about it to give you a
It
good
is
answer.
very new, I agree. And I was also planning doing a webinar on peptide, and definitely that's a topic we want to understand better here.
Yeah.
Sarah is asking us if we have better result with treating both with estrogen and testosterone.
So, oh my God, that is such an excellent question. Thank you so much for asking that. I didn't really touch on that during my talk. So, sometimes because of the low estrogen, women will present with dyspareunia, like painful intercourse, vaginal dryness, and they just have like no oomph at all. They just have no sex drive at all. The testosterone gives patients their oomph. It gives them, a better sex drive, and they feel a lot more powerful and stronger and less fatigued. So it helps with fatigue and with sex drive. So sometimes a lot of these bioidentical hormones incorporate some amount of testosterone, but like I mentioned, it is a controlled substance.
And it's something you will subscribe, right, as a OBGYN.
OBGYNs can prescribe testosterone. That's
All
correct.
right, thank you. And Sarah is also asking if you can discuss more about vaginal estrogen also.
Okay, excellent question. So we can deliver the estrogen in a pill form, we can deliver it in a patch, we can deliver it in a pump. But say someone only has vaginal dryness. They're like 48 years old, 49. They don't really want to take the pill. They don't really want to start doing the pump yet. You can prescribe estradiol, just vaginal cream. And what I usually recommend is like a fingertip amount, 2 to 3 times a week.
Thank you. Thank you so much. So I think we went all over the questions. So Lauren, thank you so much. It has been so good. I really, really wanted to do this webinar with you, and I knew it will be amazing. Um, I wanted to add something also. Like just a couple of weeks ago, we heard that Melinda Gates committed, 215 million in new funding for midlife and menopause care, and bringing our total investment to 600 million. And the reason she gave is because a lot of us need that, right? She described the scene of a woman walking to the office with huge headache, crazy symptoms, sleep destroyed, heart racing, and memory slipping. I mean, we can name them, and pretty much there is no really like diagnosis, no treatment, no plan. We feel very alone, in this journey. And she really want this to, be a menopause revolution in the country. So this is exactly what we are doing today. We're trying to get the real information, understanding that we need to find the right doctor and that we are not alone in this journey. And I want to say again what you say. I mean, we can glide into menopause with glow. So this is definitely my goal. So Lauren, thank you so much for your time today, and all of you also. I want to say thank you again, and I hope we see you in another webinar. Thank
Thank
you.
you very much, Melise, for hosting me. I'm super grateful, and I hope you guys learned a little something about this today. I'll see you
Definitely.
soon.
Thank you. Bye.